Bold, direct, and evidence-driven. From the UK, he cuts through the noise and delivers clarity. Brace yourselves. Here is Adam Meakins.
Okay, right, just give me a second to get set up. I am going to use my laptop as well, so please excuse me if I stand behind the podium for this talk. So, first things first, thank you very much to the organisers of this conference for inviting me to beautiful Tirana, a city famous for its colourful buildings, its strong coffee, and its even stronger raki, which I'm hoping I'm going to get a sample of later on this evening. So I'm really honoured to be here, but I am slightly surprised that the organisers invited a loudmouth English physiotherapist who has a reputation for upsetting people on the internet to come to such a prestigious event. I'm going to try and behave myself today. I'm going to try not to upset too many of you, but I make no promises. So today, what I want to talk about is this area here that can be slightly tricky to talk about, and that is what are the best exercises to help with painful shoulder problems. So I work now pretty much exclusively with people with painful shoulders, and I've been specialising in this area for over 15 years. And I use exercise for everybody I see who comes in with a painful shoulder, regardless of whether they're a professional athlete or a couch potato or anywhere in between. And personally, I think every physiotherapist should be using some form of exercise with every patient they see, every time they see them. And if you aren't, well, then I think you are probably not a very good physiotherapist. I did say I would try not to upset you, but I made no promises. But I'm sure, although you are using exercises on a regular basis, a bit like me, you are probably constantly searching for what are the best exercises to help people with painful problems feel less pain the quickest, but also be able to return back to things that they love doing the fastest. And that's what I want to talk to you about today. So first things first, there are obviously many different types of exercises that we could use for painful musculoskeletal problems. We have my favourites, the one that I try not to let my biases run away with me, and that is strength training or resistance-based exercises, which is without doubt one of the best ways for us to improve our muscle mass and our bone density. But then we have cardiovascular or aerobic exercises to also consider. These exercises are probably some of the best ways to increase our VO2 max and regulate our blood pressure and resting heart rate. But then we have power and plyometric exercises, which can also be great for improving our bone density and increasing our muscle mass as well. But these exercises are really good at helping maintain our fast twitch muscle fibers, which we lose as we age, as well as maintaining our tendons' natural springiness. But then we've got physiotherapists' favourite type of exercises, the good old motor control exercises, which are said to be useful for helping develop control and alignment as we do movements and activities. And then we have flexibility and mobility exercises, which are said to be helpful for improving our joint range of movement and feel less stiffness. And then finally, we have things like mind-body exercises, which can be helpful for us to relax and chill out a little bit in this very hectic life that we all tend to lead nowadays. But out of all these various different types of exercises, which is the best type of exercise for helping reduce painful shoulder problems? Is it strengthening exercises? Is it motor control exercises? Is it mobility exercises? Or is it something else? Well, I'm sure many of you have been told and taught over the years many different things about certain types of exercises being better than others for various different types of pathologies that can cause painful shoulders. For example, many are now taught in this day and age that isometric exercises are the best type of exercises for reducing pain with painful things like tendinopathy or rotator cuff issues. But I'm going to call bullshit on that, Because I see isometrics working like fucking magic in one patient, but then the next patient who walks in through the door with the same condition, it does fuck all to help them. Many are also told exercises for problems like scapular dyskinesis that are more motor control based, that are slow, developing people's control of their scapula as they move, are best to use when we see funky or wonky looking scapulas. But again, I'm going to call bullshit on that, because I see many types of exercises help people with funky looking scapulas feel better. Many are also told that when people have feelings of instability around the shoulder, they need to use isolated cuff exercises, normally done with their arm down by the side using a rubber band, to help develop stability of the humeral head on the glenoid. But again, I'm going to call bullshit on that, because I see many different types of exercises helping improve the feelings of stability with people with joint instability issues. And then finally, something as, I'm going to use the word very loosely here, simple as a frozen shoulder, simple in diagnostic terms, are said to be used exercises that develop range of movement. So capsular stretches are considered to be the best things for us to help people restore their range of movement and reduce their pain when they have this awful condition. But again, I'm going to call bullshit on that, because I see resistance training working really effectively just as much as stretching exercises does for frozen shoulders. But I'm sure you don't want to hear just my own very unreliable, very biased personal experiences of what I think are bullshit exercises and good exercises for painful shoulders. So let's take a look at what the current scientific data and evidence has to say about this as well. Let's start off with the most common cause of painful shoulders that we see, and that's the good old rotator cuff tendon problems. So things like reactive or degenerative tendinopathy, and even calcific rotator cuff tendinopathy. So in the last 5 years, there have been 3 systematic reviews published looking at 16 randomized controlled trials. Unfortunately, these are of low to moderate quality, but they have compared various different types of exercises for various different types of rotator cuff tendinopathy problems. So these trials have compared motor control exercises versus general strengthening exercises, isometrics versus dynamic exercises, progressive versus non-progressive exercises, higher versus lower intensity exercises, open versus closed chain exercises, clinic-based exercises versus exercises done independently at home, and then finally, exercises that produce pain versus exercises that don't produce pain. And after thorough systematic review and meta-analysis from all the data in all of these trials, I'm going to leave a long dramatic pause for suspense reasons. They find that all of the exercises improved pain and function roughly about the same. There is simply no evidence that any type of exercise is better for any type of rotator cuff tendon issue. So the current evidence says that there is a lot of individual variation in responses to a lot of different exercises for a lot of different painful rotator cuff problems. So despite all those claims that are out there that isometrics are the best type to help with tendinopathy problems, the evidence doesn't support this. And it's also not true that motor control exercises are any better than generic resistance-based exercises for improving function or pain when people have painful shoulder problems, despite all the social media gurus' claims. Simple exercises like push-ups, bent over rows, lateral raises, overhead presses can be just as good as isolated banded external rotation exercises. Now let's take a look at what exercises may be best to help people with torn rotator cuff tendons. Now unfortunately, there are very few trials here for us to have a look at that have used exercises to see how rotator cuff tears respond. Because most of the research on torn rotator cuff tears are normally done on surgical interventions, because this is often considered to be the gold standard treatment for people when they have a torn rotator cuff tendon. However, in the last 5 years, there have been 2 systematic reviews that have looked at 6 randomized controlled trials that have compared rehab interventions, exercise-based interventions, for both acute and chronic rotator cuff tears compared to those individuals that go and get surgical repair. Now, unfortunately, these trials are of low quality, meaning that we can't make any strong conclusions from these studies, but the first thing they found was that there was no significant difference in the outcomes of pain or function between the different rehab groups in these different trials, despite them using different exercises and different protocols. However, they did find that the surgical groups had a small statistical benefit in their pain reduction and functional improvement over and above those that just did exercises and rehab. But here's the really important part. When you look at the statistics and the minimal clinical important difference of these outcomes, you find that it doesn't reach the minimal clinical important difference required. And this was something that Vasilios was talking about when you are reading research. You always have to read research critically. Research can sometimes be used like a drunk uses a lamppost, more for our support rather than to illuminate where we're trying to go. The other thing I always say about research and statistics is statistics are a bit like bikinis. Bikinis reveal things that are very interesting, but they hide things that are even more interesting. So when you are reading research and statistics, make sure you peek underneath the bikini. Now next, let's look at the very controversial area of using exercises to improve or try to correct so-called scapular dyskinesis. This is often said to be causative of many shoulder issues for causing things like impingement of the cuff between the acromion and the humeral head. Well, there has been one systematic review published in the last 5 years that has looked at 20 different trials comparing scapular strengthening, stretching, and motor control or stabilizing exercises in those with subacromial painful shoulders. Now, unfortunately, again, most of these trials are very low quality, meaning that we have to be careful with drawing any strong conclusions here. But they found that all these exercise trials improved pain and function, again, about the same. But more importantly, these trials also showed that there was no evidence that any exercises that you give people with scapular dyskinesis actually makes a significant change in the subject's scapula's resting position or how it moves. Now, so this is telling us that our exercises improve pain and reduce function, but their bodies are still moving the same way. Now, I think this is in part due to a number of reasons. One is due to the incredibly poor reliability of being able to assess scapulars either at rest or during movement. But I also think this is due to the incredibly wide variation that we see in scapular postures and movement in human beings, meaning that we're actually unable to define what is normal and what is dyskinesic. I think most of what we are calling and classifying and labeling as dysfunctional scapular dyskinesis, apart from the very rare neurological lesions and issues, is most likely perfectly normal, healthy, natural variation in scapular posture and movement between individuals. Now let's move on to shoulder osteoarthritis. And this is rather embarrassing to talk about because after obviously many decades of conducting research in musculoskeletal issues, there are 0 randomized controlled trials that have been looking at exercise interventions on people with shoulder osteoarthritis. There are only a few limited small case series that don't have any control or comparator groups. Again, 99% of all the research on shoulder osteoarthritis is done on invasive, interventional, surgical or injection techniques. But based on these very few small case series, there is some evidence that exercise can help improve pain and function in people with glenohumeral joint osteoarthritis. But like I said, we can't make any really strong conclusions here. Now next, let's look at probably one of the most horrible and miserable and painful shoulder conditions that I see in my patients, and that is the dreaded frozen shoulder, adhesive capsulitis, which Rolf talked about already, a horrible multifactorial condition that causes severe levels of pain for incredibly long periods of time. Now, in the last 5 years, there's been one systematic review that's looked at 33 trials. And again, unfortunately, these trials are of low to moderate quality. They have compared various forms of assisted or passive stretching done by a therapist to stretching that's been done by the patient themselves. Some trials have looked at the use of shoulder strengthening and stretching exercises, and some have compared the use of muscle energy techniques like PNF, contract and relax, against assisted stretching exercises. And some have also compared the use of painful exercises versus exercises that are pain-free. And yet again, after systematic review and meta-analysis of all the data in these 33 trials, there is no evidence that one type of exercise is any better or worse than any other exercise at helping reduce pain or improve function in people with frozen shoulders. And then finally, let's take a look at the use of exercise to help people with shoulder instability issues. Starting off with non-traumatic instability, usually due to some form of hypermobility syndromes. So there has been one systematic review conducted in the last 5 years that has only, unfortunately, one randomized controlled trial included, 6 cohort studies, and 3 small case series. So again, we're going to have to be careful with making any strong conclusions here. The only RCT in this population compared the use of motor control exercises versus generic strengthening exercises, and the cohort and case series studies looked at things like movement re-education exercises, as well as the use of biofeedback devices and postural correction devices to help improve feelings of stability. And guess what? No surprise, yet again, after systematic review of this data, there is again no evidence that any one type of exercise or approach is any better at improving the stability or function in people with non-traumatic glenohumeral joint instability issues. So now let's take a look at traumatic instability, normally from those that have suffered sporting accidents and dislocated their shoulders in martial arts or playing contact sports. Unfortunately, again, there are no randomized controlled trials done here comparing the results of different exercises or rehab. Again, most of the research here is comparing surgical interventions versus rehab. But there has been 22 randomized controlled trials. And again, after systematic review, there is no evidence that there is any type of best exercise or optimal rehab procedure that helps improve function, range of movement, or stability in those that have suffered classical traumatic shoulder dislocations. Now, after the systematic review of this data, this also tells us to say that there is no optimal best approaches. However, what they did find rather interestingly was that the surgical groups did have a significantly reduced risk of a second dislocation in the following 12 months compared to the rehab groups. But there is very wide confidence intervals here, meaning that when you actually look at that risk, is anywhere between a 20% risk to a 97% risk. So again, we don't really know how much of a risk that is. Why surgery seems to reduce the risk of a second dislocation compared to rehab interventions alone, I think is due to many factors, but I think this is a topic for another talk and I won't want to get into that too much today. So, in summary, there is absolutely no evidence of any superiority of any type of exercise for any type of painful shoulder issue, be that rotator cuff tendinopathy, rotator cuff tears, frozen shoulders, possibly osteoarthritic shoulders, or unstable shoulders. No matter what your professors at university have told you, or your favorite social media influencers put on social media. The scientific facts are there is no type of exercise that is better than any other for painful shoulder problems. However, there's always a however, I am going to state that you will definitely be able to find some evidence of superiority of one type of exercise over another when you do search the literature. But again, this is going back to what Vasilios was saying earlier. The quality of these studies is often very poor, and it's normally only done on small numbers of subjects, on very specific populations, with no control group or comparator, or they are just highly biased and designed poorly with no explanation of things like randomization or blinding processes. Again, this means that these trials you are unable to make any strong conclusions from, even though they are often used to make strong conclusions. So, the bigger and I think much more interesting question to ask about exercise for painful shoulder problems is, why is there no evidence of any best exercises? And more importantly, if there is no best exercise, then where the fuck do we start when it comes to trying to choose exercises to help people with painful shoulder problems? Let's start off with the first question. Why are there no best exercises? Well, the main reason that there are no best exercises for pain is simply because all exercise can affect pain through multiple overlapping mechanisms: biological, physiological, and social. This makes exercise one of the most truly multimodal treatments that we have at our disposal. Exercise doesn't just affect tissue or biomechanics. Exercise affects people and systems. Exercise can improve physical properties of our tissues, of course, but it can also improve our circulation, our metabolism, our systemic inflammation. And it also releases a wide range of pain-inhibiting hormones and molecules, things such as endorphins and myocytokines, which can all, again, reduce our feelings of pain. But exercise also has physiological and social effects that also can have huge positive effects on our feelings and perceptions of pain. Exercise can reduce our fear of movement and improve and boost our confidence and mood. Exercise could also just be a great big huge distraction and help us develop some routine and structure into our lives when pain disrupts it. Exercise also comes with increased social interaction, something that is often also quite often forgotten and overlooked. And this can help improve our connections back into society and have huge positive impacts on our quality of life. Out of all of these biological, physiological, and social and psychological areas, we simply do not know which one of these, or combination of these factors, is doing the heavy lifting when it comes to helping reduce somebody's pain. We cannot simply say with any certainty what are the mediators or moderators of change in pain when we use any type of exercise, because so many of them are overlapping and working together at the same time. Unfortunately, however, this is not well recognised by a lot of physiotherapists and particularly patients. Many of us only tend to look at the tip of the iceberg and think that exercise helps with the pain and disability based on a few limited biomechanical effects. But when you actually start to look under the water and recognise all of the hundreds, if not thousands, of other factors that exercise can also affect, that could also be contributing to reducing somebody's pain and instability, this starts to open your eyes and also open your options of choosing exercises to help people with shoulder problems. This knowledge about the multimodal effects of exercises gives us much more freedom and flexibility to use exercises to help people with painful problems. Another important aspect to consider when it comes to using exercise is that probably over 50% of the effects of exercise on pain are non-specific and all contextual. So these things could also be contributing to reducing pain. We have to always remember that mysterious and uncontrollable effect called the placebo effect is always working in the background of everything that we do. But we also have to consider that the effects of time could be helping a lot of people feel better when we give them exercises. Fortunately for us, most of our musculoskeletal issues that we see in patients have favourable natural histories over time, meaning regardless of what intervention they use, they are slowly getting better thanks to natural healing. But we also have to accept that maybe some of our treatments are also just helping people be amused whilst time is curing them. And then we've got our contextual factors to consider. Simply listening to your patient's problems and caring about their issues can, giving them some reassurance around that, could also be a factor that helps people feel better when we give them exercise-based interventions. Now, with all that being said, just because any or all exercise can reduce pain, I don't think that means any exercise can automatically reduce pain. Please do not think for 1 second that just because the evidence says there is no best exercises, it means you can switch your brains off and just start giving any random exercise to a patient and that will magically help them. Just plucking things out of the air and giving people random exercises, okay, without any thought or consideration, I think is a guaranteed way to get very poor outcomes, as well as being a really shitty, lazy, uncaring way to be a physiotherapist. So the next question is, how do we go about choosing exercises better for people with painful shoulder problems? Well, very simply, we need to switch from using exercises to fix people's pathologies to using exercises to address people's problems. People want to lift grandchildren, not do seated, isolated, banded external rotation exercises. The evidence clearly tells us we don't need precise pathoanatomical diagnoses to use or choose exercises better. But I do think we need to choose exercises that address people's issues, disabilities, and aligns with their goals better. So instead of choosing exercises based on your diagnosis of rotator cuff tendinopathy, choose an exercise that addresses what this pathology is affecting the most and what that person wants to get back into. So is this rotator cuff pathology affecting their ability to reach overhead or behind their back or out to the side? Is it lifting their grandchildren, or is it lifting a bag of shopping? It's these issues that will help guide your exercise selection so much better than your pathoanatomical diagnoses. Another important factor to consider when it comes to using exercises for painful issues, be it in the shoulder or anywhere else, is making sure that we dose the intensity of that exercise well to also get good outcomes. If you give a patient too much intensity and flare their pain up too much too quickly, you will quickly lose their trust and they're unlikely to come back and see you and do it again. However, if you give too little intensity to an exercise, then often the adaptations that we want to occur may not, and improvements may not be made. I find my mate Ben Cormack's rule of 10 quite useful here when it comes to trying to decide how much intensity to give somebody. This simple guideline says, if you have a patient with high levels of pain, then you're going to keep your rehab intensity at a lower level. Ideally, try to keep this number below 10 when you're looking at the rate of perceived exertion during their exercises and their current pain score. However, if a patient has, not very much pain, then it allows us to obviously think about increasing the intensity of our exercises. Now, although I think trying to keep this number below 10 is a useful guideline, I don't think it's always possible, and I also don't think we always have to do this with some patients. I think if we try to think about avoiding pain all the time, that can be sometimes problematic when it comes to rehab. I think a little bit of painful rehab for some people in some situations can be really effective, and there is evidence out there that says it can be as well. However, who these patients are and who gets better responses from painful rehab exercises is still very hard to determine. We often find that those with signs of maladaptive central nervous systems, with maladaptive nociplastic pain, often are the individuals that don't do very well with painful rehab. But for patients without these type of signs or symptoms, painful rehab can be really effective in reducing pain and improving their feelings of confidence and control over it. Something else that I'm also keen on promoting when you are giving exercises for painful problems is promoting simplicity over complexity. Less is more. A general rule of thumb is the less exercises you use and the simpler they are, the more likely they are going to get done by your patient. I personally very rarely give any of my patients more than 2 or 3 rehab exercises to do at one time. Often, I'm asking most of my patients to focus on just 1 or 2 things at a time. Doing one exercise really, really well will always outperform doing 5 or 6 exercises poorly or not at all. And contrary to belief, I also don't think you need to ask many patients you see with painful musculoskeletal problems to actually do that much rehab exercises to start to get improvements. My advice is for most patients, start them off with just 30 minutes a week, not 30 minutes a day. How you decide to break that 30 minutes a week down will depend on the persons in front of you, their irritability, their levels of pain, but also their lifestyle and other commitments and time that they have. For most of my patients, I find breaking that 30 minutes down into 3 chunks of 10 minutes, normally on a Monday, a Wednesday, and a Friday, is a good starting position. And then I give them the weekend off. Do something else on the weekend that's much more meaningful for you and go and enjoy that and don't worry about your rehab. I find for most patients this is very achievable and realistic, and it's more likely to get done. And it gets them into an engaged routine with their rehab that I can then start to develop and build on from there. So I don't think you have to always stay at 30 minutes. It's a good starting position a week to try and get them engaged and moving forward as things improve. The other thing that I think patients need to be aware of is we need to talk about how long normally rehab exercises take before they start to make people feel better significantly. Most people expect exercises to start to feel better within a couple of weeks. I often tell patients most of the time they need to be grinding these exercises out for 2 to 3 months. I am a big believer of trying to create a little bit of variation for people because it can help with engagement, but I think too much variation is the enemy of progress. Sometimes consistency and doing the same things repeatedly is what's needed. So we do need to manage patients' expectations about how long things take before they start to feel better. And everybody, unfortunately, you, me, and patients all underestimate the natural time factors of these things. Very few things that cause painful shoulders are going to feel significantly better in 6 weeks once they start a bit of treatment. For most rotator cuff issues, the average time before improvements are really noticeable is closer to 6 months. But something like a calcific tendinopathy, it could be even longer than that, it could be up to 12 months. And for something really horrible like a frozen shoulder, the average time for reported improvements is 30 months, nearly 3 years. So please do not underestimate your patient's natural history and recover times, because if you do, and these things are not met and their expectations aren't managed well, it will confuse them, worry them, and stress them out, and often lead them to go in seeking unnecessary further treatment investigations. And then the last thing, and this should go without saying, is obviously when you are helping people do their exercises, care deeply about their problems and their issues that they've got. Demonstrate that you give a shit about your patient's problems. This goes such a long way in helping people move forward and start to improve. So work hard on building your patient's trust and respect. Because after 25 years of doing this job, I've come to realise that some of the best results I've got with my patients is not to do with my amazing assessment techniques or my superior exercise selection skills. It's happened because I've got a better, stronger therapeutic relationship with them. And that I've earned this person's trust and respect and confidence. And it's these factors that tend to help people progress and move much more forward. So in summary, all exercise is good exercise for any type of painful shoulder problems. And there is no evidence that any type of exercise is better or best for any other type of shoulder problems. So please do not limit or constrain yourselves to certain exercises or protocols based on one poorly conducted research trial. And also don't limit yourself from choosing exercises just purely based on your pathoanatomical diagnosis. Also, you don't need to give your patients too much exercises, and you certainly don't need to overcomplicate it. As I said, 30 minutes a week is a good starting position. And at the end of the day, the best exercise is really the one that's getting done on a regular, consistent basis. Thank you very much. Any questions?
We have some questions.
Okay.
Thank you, Adam.
here. I'm very happy to hear that. So my question is, we saw that the research is confusing and getting a lot of the data which very good. Unfortunately, there are also some researchers that are saying this is good, this is that, but anyway, this meta-analysis and systematic review clearly reveals that the shoulder problem is very complex and we need to have a big experience to deal with this. So I just wanted to know when the origin of the pain is not on the shoulder, kind of the non-specific diagnosis. So I have faced with the woman athlete. She was a handball player, having always complained the pain on her right shoulder during throwing the ball and in the competition. And diagnosed it from the orthopedist as a rotator cuff injury, as they know to say that. And everyone was focused on that. So I tried to do some best, but when I started to make evaluation, as in a holistic way, I found out that 4 years ago, she was broken the big toe on the opposite foot. And during jumping and during throwing, always there was some movement biomechanically up to her shoulder. And then I was successful only when I have started to treat in holistic, starting from her toe, the foot, and all the body joint up to the shoulder. After we did some progress, and now she is continuing to do the job. Did you face with this kind of or maybe you have a lot of experience in this area?
So the kinetic chain is involved, when people are doing tasks and movements of their upper limb, their trunk and their lower limb is going to be contributing in something like throwing and athletic type of activities, then that could be having a more greater impact. But for most people with day-to-day activities, I think the kinetic chain involvement is going to have a minimal impact. Obviously, the higher the intensity of the exercise that they're doing, the more likely it is. How far down the kinetic chain we can start to tie things together. This is where I think it starts to get a little bit crazy and goes into the world of pseudoscience, where we start to think about, little toes being the problem causing shoulder issues. It's theoretically possible. Do I think it's high on my list of potential reasons as to why somebody has shoulder pain? I'm going to probably say for most people, no. But I do think looking at people holistically with their painful shoulder problems and recognising that just because they feel it in the shoulder, the problem might not be actually in the shoulder. We know, pain can be referred from other structures and areas. Is important to make sure we screen people, globally as well. Yeah.
Thank you.
Thank you.